Hello everyone, welcome to Easy Medicine. The topic that we are going to discuss today is coronary artery disease. It's a huge topic and hence I divided it into two parts. In the first part, we are going to look at the coronary artery disease, its risk factors, pathogenesis, and clinical features. In the second part, we'll discuss about the evaluation and management of coronary artery disease. So, the coronary artery disease has been divided into stable angina, unstable angina, non ST elevation myocardial infarction, and ST elevation myocardial infarction. Now, we call unstable angina and non ST elevation myocardial infarction as non ST elevation acute coronary syndrome. The only difference being the presence of cardiac troponins or the troponin positivity in STEMI, and it is negative in unstable angina. In this first session, we are going to discuss all of them together. We are going to discuss NSTEMI, STEMI, as well as angina together, and we are going to compare them side by side. Whereas in the second session, we are going to look at the management of each and every one separately. Now, let's start with the coronary artery disease. So, like I told you, we are going to discuss the risk factors, pathogenesis, and clinical features. So, what are the risk factors? We have modifiable risk factors as well as non modifiable risk factors. The modifiable risk factors are the tobacco exposure, hypertension, dyslipidemias with increase in LDL, reduced HDL, and increased cholesterol levels, hypertriglyceridemia, diabetes, metabolic syndrome. So these are some modifiable risk factors, and we have non-modifiable risk factors as well. The important one is family history. The family history of premature cardiovascular disease, it could be fatal or non-fatal at the age of less than 55 years in men and less than 65 years in women. We have certain genetic causes as well. Some of them are familial hypercholesterolemia, often caused by mutations in LDL receptor, ApoB protein, or PCSK9 genes. Chronic kidney disease, cerebrovascular disease, and peripheral vascular disease as well. And in women, usage of combined oral contraceptive pills, usage of hormone replacement therapy, and preeclampsia can also predispose the patient to develop coronary artery disease. These are some factors that we need to remember. Now, there are certain medical conditions that are associated with increased coronary artery disease risk. Not directly a risk factor, but there is correlation. They are anemia, hypo or hyperthyroidism, rheumatological disorders like gout or rheumatoid arthritis, because in most of the connective tissue disorders, there is axle-related atherosclerosis, and that predisposes the patient to develop coronary artery disease and even atrial fibrillation. These are some medical conditions that are correlated with increased risk of coronary artery disease. Now let's look at the anatomy of the artery. So when you look at the outer end, there is tunica adventitia, and when you gradually move inwards, there is tunica media, which is composed of smooth muscles, and then you have tunica intima, and then you have endothelium. So these are the layers of the arterial wall from outside to inside. Let's look at the pathogenesis. So in the presence of low HDL, high LDL, and endothelial damage, the LDL in the lumen diffuses across the damaged endothelium and accumulates in the intima. What happens in the intima? The LDL is oxidized. The oxidized LDL triggers inflammation and recruits macrophages. The macrophages which are recruited now will engulf these LDL droplets and transform themselves into foam cells. Foam cells are nothing but macrophages with intracellular lipids. Now, they cannot survive for long, right? Because of ongoing inflammation, recruitment of further neutrophils, lymphocytes, what will happen? The foam cells are eventually going to die and they will leave the lipid droplets extracellularly. So, there is necrosis of these foam cells and other inflammatory cells, and along with that, there are extracellular lipids. That is what you call it as the lipid necrotic core. Now, in order to contain this inflammation, our body is going to mount a response, and fibroblasts are recruited, and fibrous tissue keeps on depositing around the lipid necrotic core. So, there is a thin fibrous cap and a lipid necrotic core here. That is called as the fibrofatty plaque. This is when the patient may develop chest pain on exertion. That is what is called as stable angina. The thin fibrous cap rupture and eventually expose the interior of the lipid necrotic core into the lumen. What happens? That will result in the formation of thrombus and it will eventually heal. So the repeated cycles of thin cap rupture and thrombosis and healing occurs again and again and again until the arterial lumen is compromised to such a state that the heart will develop ischemia even at rest. That is when the patient will have unstable angina or NSTEMI. Together you call it as NSTE ACS. And further, there is deposition of the calcium also, and there is formation of nodules. And eventually, multiple cycles of this will finally result in complete occlusion of the artery, and the patient will have ST elevation MI. That is, there is infarction. So here is all again represented in the form of an image. As you can see here, here are the LDL particles. Because of damaged endothelium, the LDL particles are going to enter inside, and the LDL is going to be oxidized. The oxidized LDL will be engulfed by the macrophages, and that is what is formed. That is what is called as a foam cell. These foam cells will eventually die, and they get necrosed, and the intracellular lipids come out because of necrosis. And after the cells die, the intracellular lipids become extracellular, and all these lipids are going to deposit in the intima, forming a lipid core. And along with the cellular debris, we call it as a lipid necrotic core. And in order to contain this inflammation, there is a recruitment of fibroblasts, and there is formation of a thin fibrous cap. That is what has been explained here. Now let's look at the clinical features. So we are talking about the clinical features of stable angina. Every pain, I would like to explain it using an acronym, that is Socrates. S for site, O for onset, C for character, R for radiation, A for associated symptoms, T for timing, E for exacerbating and relieving factors, and S for severity. Now let's start with the site. The site is usually central or substernal, and then the patient places the hand over the sternum with a clenched fist. This is called as the Levine sign. So the usual site is central or substernal, and the onset is usually gradual or crescendo decrescendo. There is a gradual increase and gradual decrease in the chest pain. And character is heavy or squeezing or smothering or choking type. There is the patient usually complains of discomfort, mild discomfort, and it can be a gripping kind of sensation or a heavy sensation or a squeezing sensation. The radiation is towards any shoulder. It could be to the right shoulder or it could be to the left shoulder, ulnar aspects of the forearm and hand, sometimes to the epigastrium, back, neck, and the lower jaw and teeth as well. Usually, when we look at the radiation can extend anywhere between the lower jaw and the umbilicus. All this area can be the area for radiation of this anginal pain. And this will not usually radiate to the trapezius because the trapezius radiation is characteristically seen in acute pericarditis. The associated symptoms are usually nausea and fatigue, and the timing is usually less than 10 minutes. The duration of chest pain is usually less than 10 minutes. The exacerbating factors are emotions and exercise, whereas the rest and nitrates will relieve the chest pain. And severity is usually mild to moderate. Characteristics of a typical anginal chest pain. The three main characters are the location, that is, the patient will have a substernal chest discomfort with characteristic quality and duration. The second point is it is usually provoked by exertion or emotional stress, and it is relieved by rest or nitroglycerin. If all the three characters are present, then it is typical angina. If there is 2 out of 3 characters present, then it is atypical angina. If there is 0 or 1 character of chest pain, then it is non-anginal chest pain. So, what are some atypical symptoms and anginal equivalents? Atypical symptoms are more commonly seen in women than in men. The symptoms are fatigue, abdominal pain, nausea, vomiting, dyspepsia, and sometimes sharp chest pain as well. Usually, the sharp chest pain is characteristic of pericarditis or pleuritis, but it is considered as an atypical symptom which is commonly seen in women. And there are certain symptoms called as the anginal equivalents, and they are commonly seen in elderly and diabetics. The patient will not have chest pain, and the patient will have some other features. What are they? Again, the patient can have dyspnea, nausea, fatigue, and dizziness or faintness. So these are some atypical symptoms and anginal equivalents that are associated with angina. Now let's look at the stable angina, unstable angina, NSTEMI, and STEMI. From the pathology, hope you have an idea about what is happening. Let's just revise. So when you look at the pathology, there is a fixed atherosclerotic plaque. So when there is a fixed atherosclerotic plaque, at rest the patient will not have chest pain. Only when the patient exerts, there is more demand of heart for blood. With the compromised lumen of the artery, the increased requirement may not be met. That is when the patient develops chest pain. So in stable angina, the patient will develop chest pain only with exertion or emotional stress. In unstable angina, there is a ruptured plaque with partial occlusion. We have looked at the image. But here there is only ischemia. That is why the patient is having pain, but there is no infarction here. In the NSTEMI, here also you can see a ruptured plaque with partial occlusion, and here there is infarction. What kind of infarction? Because the epicardial coronaries are going to supply the blood from the exterior, The outer part of the myocardium will get sufficient amount of blood flow, but the innermost area or the subendocardial myocardium is what is getting infarcted. And in STEMI, there is transmural infarct. The ruptured plaque will result in complete occlusion of the arterial lumen, and there is a transmural or a full thickness myocardial infarct. That is what is the pathology here. Now, what kind of chest pain will be there? Of course, we have already discussed in stable angina, it is predictable. Predictable in the sense the patient will have chest pain only when he exerts. So it is exertional and relieved by rest or nitrates. In unstable angina, the chest pain is new onset and occurs at rest or with minimal exertion, and it will last more than 10 minutes. It is less than 10 minutes in stable angina. And in STEMI as well, the pain is similar to that of unstable angina, but it is little more severe because there is some infarction there, and again it also lasts more than 10 minutes. STEMI, the patient will have a severe crushing and prolonged chest pain, which is not relieved by rest or nitrates. You can see the rest or nitrates will relieve the pain of stable angina alone. It is not going to relieve the pain of unstable angina in STEMI or STEMI. And the duration of chest pain will last for more than 30 minutes, because if you don't treat the patient will keep on having chest pain. Let's elaborate the chest pain. The site is usually laterosternal, and that is same with the other three as well. In stable angina, it is usually gradual with exertion or stress, whereas in unstable angina, it is sudden and it can arise at rest or minimal exertion. The same is seen with STEMI as well, and in STEMI, it is sudden but it is often very severe. And the character is usually a pressure, tight, squeezing, or heavy kind of discomfort, and it is same in unstable angina and in STEMI, whereas in STEMI, it is crushing and there is severe pressure. And the radiation is to arms, neck, jaw, and abdomen above umbilicus. The same radiation can be seen with all the other three as well. And when you look at the associated factors, the patient will have dyspnea and fatigue. In unstable angina, the patient can also have diaphoresis in addition to them, and sometimes nausea. The same will be seen in STEMI as well, and the same along with sometimes syncope. Of course, there are some atypical presentations of STEMI as well. We are going to look at them in the last. The timing. The timing is usually less than 10 minutes in stable angina, more than 10 minutes in unstable angina, and it is more than 10 minutes in STEMI, and it is usually more than 30 minutes and it is not relieved by rest or nitrates in STEMI. Exacerbating and relieving factors. Exertion or stress will exacerbate the chest pain in stable angina. No exertion may be required because the patient will have chest pain at rest or even with minimal exertion in unstable angina, in STEMI, or STEMI. The rest or nitrates are going to relieve the chest pain in stable angina, but that is not the case with all the other three. And lastly, severity, it is usually mild to moderate, and in unstable angina, it is moderate to severe, and in STEMI, it is usually severe. These differences are made for the proper understanding and they are not absolute. Okay. Can you see the features of heart failure in these patients? The heart failure is usually absent or very rare in case of stable angina because the patient is only going to have the chest pain on exertion, but as soon as the exertion is relieved or the patient comes to rest, the chest pain is relieved and the ischemia is also gone with proper perfusion of the arteries or the myocardium. So in unstable angina, it is possible with transient dysfunction of the left ventricle. And in STEMI as well, there is subendocardial infarct and hence the heart failure is possible. In STEMI, the heart failure is so common. So what are some atypical presentations? Without the chest pain itself, the STEMI can present with sudden loss of consciousness or sudden onset of shortness of breath with pulmonary edema. And sometimes the reduced blood flow to the brain because of hypotension and shock, the patient will end up in confusion. And the patient can also have severe fatigue and weakness, and certain patients can experience anxiety and the feeling of impending doom, like a panic attack. So these are some atypical presentations that are commonly seen with the STEMI. Now let's look at the features of clinical examination. The clinical examination in a stable angina is usually normal, but in an unstable angina, the patient can have tachycardia, hypertension, or hypotension depending upon the area of infarct, and the patient may have S3 or S4, new onset mitral regurgitation because of papillary muscle dysfunction, bilateral rails is because of the left ventricular failure, and any sign of heart failure may be there, like elevated JVP or pedal edema can also develop. In STEMI, the features are same and they are more common in STEMI rather than unstable angina. And when you look at STEMI, all these features are present. In addition to them, there is anxiety, severe distress, tachypnea, and all the other features that we have discussed in the unstable angina can also be seen. Now let's look at the evaluation. So what the first step would be to look at the ECG, right? ECG in stable angina is usually normal. You can also appreciate ST depression and T wave inversion only when the patient is having pain. In most of the instances, the patient had pain, the patient would have had pain at home, but while the patient comes to the hospital, the patient may not have any pain, and ECG is commonly normal. So that is why we need a proper evaluation and stress testing for evaluating a case of stable angina. But in unstable angina, the patient will have ST depression or T wave inversion, and there can be transient ST elevation as well. The same features can be seen with the NSTEMI as well. And in STEMI, persistent ST elevation of more than or equal to 2 millimeters. In STEMI, you can see persistent ST elevation of more than or equal to 2 mm in at least two contiguous leads. Troponin levels. The troponin levels are usually normal when there is no infarction. So in unstable angina and stable angina, the troponins are normal. But when you come to NSTEMI, there is subendocardial infarction and there is release of troponins into the circulation. That is why they are elevated, and it is usually more than 99th percentile at 0 or 1 hour. That is diagnostic of NSTEMI. This is the sole difference between unstable angina and NSTEMI. The clinical presentation entirely can be same. ECG changes can also be same, but when you look at the troponins indicate whether there is only ischemia or there is infarction also. And again, in STEMI, there is elevation of troponins. Now, how do you want to manage? In stable angina, there is only ischemia and you want to relieve the angina, so you will use anti-anginal drugs. And after stress testing and coronary angiography, if you feel that reperfusion is essential, then you may do PCI or CABG. Whereas in unstable angina, you will treat unstable angina and STEMI or and NSTEMI as the same, because when you and when you when and when you talk about unstable angina and NSTEMI, they are two parts of a close continuum, and hence you are going to treat both of them similarly with anti-ischemic drugs, antiplatelet drugs, and anticoagulants. And if required, you may have to do reperfusion with the PCI, that is primary coronary intervention, or coronary artery bypass graft. The same is the management of NSTEMI as well. We are going to elaborate each and every one of them in the subsequent lectures. In STEMI, in addition to all the modalities that we have seen in NSTEMI, you can add up thrombolysis here. Thrombolysis is not proven to be having any benefit in unstable angina and NSTEMI, whereas it has been shown to have significant benefit in STEMI. That is why we give thrombolysis in a case of STEMI, but not in NST elevation acute coronary syndrome, that is in stable angina and NSTEMI.